researcher. She is a Wellcome Trust Research Fellow in Health Informatics. Her background is in health psychology, her PhD in digital health and health behaviour from University College London. And her topic is particularly relevant to some of the subjects that our centre is running right now, and to a number of people who follow us online and who are associated with us through research and study. So, Paulina, take it away.
Thank you. Very good memory, Kathleen. So today I want to talk to you about this meaningful AI-human collaboration. So I'd like to talk to you about machine-assisted topic analysis, social inequalities, bias mitigation. Cara took this fabulous picture of me in Melbourne, and I must say, if anyone needs a picture taking, ask Cara. It's absolutely fabulous. I'm going to update it for everyone.
She was a photographer.
Yes, I remember that. Yes. Absolutely. So my background is in digital health, in health psychology. So how to develop interventions for people who live with chronic conditions, how to help people change their behavior, how to prevent disease. And I do research within academia. I also worked for 3.5 years in public health organization. I was very unlucky that that was Public Health England. I was running around GP clinics, asking them how they talk about physical activity to patients, going to supermarkets, looking at how they show healthy produce, whether we can do some trials in an online shopping basket to do some healthy swaps. And then pandemic hit, and that was it. Move everything. We were working on a pandemic. The good thing that came out for me is this project, because it came from a real need, and that's what I really wanted to talk to you about today. So the outline of the talk is sort of the development and validation of MATA, which is machine-assisted topic analysis, the practical application of the analysis for one of my passion projects, which is evaluation in digital health, or lack of evaluation. And then I'll move on to speak about improving MATA, which is Humble framework. So this is something I got funding for. It's a Wellcome Trust for 4.5 years. And this is improving this machine-assisted topic analysis, but focusing on experience of underserved groups and looking at bias mitigation. So this is NHS Test and Trace system, which was the system designed to manage everything within the pandemic in England. So from identification to testing to tracing to giving isolation support and advice, and bringing back humans into community once they are recovered. So this is NHS Test and Trace. Now, on the right-hand side, you can see the text box asking the user to rate the service from very satisfied to very dissatisfied. And there's a little text box saying, how could we improve the service? Let me give you one quote. Too many phone calls, all asking for the same information, expecting me to talk for 30 minutes whilst my father was dying from COVID-19 after having a hip operation, and then receiving yet another phone call asking me to talk for a further 20 minutes. My father passed away today. So this is a response to an open-ended question from a very dissatisfied user. Now, this is one out of more than 500,000 responses that we have. Now, I'm a public health professional. I'm a behavioural insights advisor trying to make the best out of this situation in terms of trying to help wherever I can. And we were all doing the same in civil service. So at some stage, my boss said to me, there's this data on feedback from NHS Test and Trace. I know you're interested in digital health. Would you want to analyze it and provide feedback for next day for program board? So I didn't know anything about this. I said, yes, please just send it to me. I'd love to do that. And then I'm opening the file only for the dissatisfied and very dissatisfied, and it's 16,000 responses. And that was 2 months into running of the service. This was the first situation in my life where I actually didn't know which side I should really buy data. Sort of, it's for tomorrow, there's program board, and I've got 16,000 on my plate. So that was really, really difficult, but that was more than, well, 3 years ago now. And since then, really, I was on a mission to get this data analyzed. So using qualitative analysis, we were only able to analyze 0.18% of data. And using this method I developed, which is called machine-assisted topic analysis, we managed to get the subset of data analyzed, but it's still 6.6% of the data that's been analyzed. So the methods we use, so something I wanted to mention is that I am not a data scientist. So this is why I couldn't just see, okay, I'm just going to run this modeling and it's going to be great. I tried to, at that stage, I tried to reach out to so many people. I couldn't get help. At some stage, a head of digital science in Public Health England said, okay, Paulina, I'm just going to do it all on the weekend. I'm just going to help you. And, you know, that's how mad it got during the pandemic. But he couldn't help me. He did some clustering. The data didn't make sense. He did some sentiment analysis. I wasn't sure what I was doing. He wasn't sure how to help me. So long story short, we tried different methods. Finally, I got someone employed with some data science skills in the behavioral insights. And together we used structured topic modeling on those 38,000 responses. So this is an unsupervised machine learning approach with document level covariates, document level meaning feedback, those user feedback level covariates, looking at prevalent topics feedback. And there's diagnostics you can run, and humans have to sort of tell the machine how many topics you want, but there's a diagnostics you can run, and 25 topics were deemed best fit at that stage. And then after those topics were created, we mimic thematic analysis as a qualitative researchers to see, okay, machine gives us this kind of topics. What can we do with that? Can we do anything with that? So it's very much exploration. So 19 topics from those 25 were included in the qualitative analysis because it made sense. And that's one of the limitations of the method. I appreciate that. But these were grouped then into 3 major themes. And these represent the family of issues. And this would be major themes for those of you who are qualitative researchers. So the first one was multiple contacts and incompatible contact method. So I mentioned to you, many phone calls were received per one household that was on the verge of harassment, especially when people are feeling ill or had to deal with actually family member who was dying of COVID. Confusion around isolation days and tracing delays, and complexity of the system and rigidity of the system. So I love a good mind map. So this is something I developed. I know that you can't see it, but the whole idea of this method is that on the right-hand side, these are the topics that the machine analyzed. And what we did is me, myself, and another researcher separately analyzed the data to sort of try to make sure that maybe some of the subjectivity will be minimized. We'll then come together, describe what the topic is about, and see whether we could make sense out of it, if it's valuable or not. And this is something that's a result of this analysis. So let me just show you on one example how the method looks like. So multiple contacts and incompatible contact method. So these topics were included, and the description of the topic is not provided by the machine. You have to decide yourself what the topic was about. So within that topic, topic 14 was, for example, we called it too many calls received. Second one, multiple calls per household received. Third one, multiple calls for a household, reiterating the same process. So as you can see, these are quite similar topic, yet slightly different in terms of the community of words, as I call it, that the machine analyzes and puts together in terms of frequency. And then we try to group them together as a qualitative researcher would. So let's just look into what we asked the machine to do. So one of the topics it created, we asked it to create 10 representative quotes. You can ask for as many as you like, but we asked for 10 of them to analyze this data. I know, again, you can see, but let's say they have been called multiple times, 25 times. I think he said they feel unwell and are very unhappy about how many times they have been called. She's not happy with the amount of calls, called a lot of times, fed up, feel harassed, too many unnecessary calls. Now, these are the actual feedback I showed you from the participants. Now, there is no, I can see the value of this approach, because as a public health professional working in a pandemic, last thing I want to do if I have little time is sift through all those information, because actually my intellectual capacity is somewhere else. I was doing that and I could see myself, my fatigue kicking in after a while, and actually my error rates increased, because this is not what humans are supposed to do for hours on end. Machine is very good at doing that, and they're very similar. So the second one was sort of conflicting information about isolation dates, asking users to self-isolate when they were actually already doing that, being desperate to try to connect with someone, saying, no, you told me to isolate for such a long time, but actually I've already been isolating. So something about that needs to be improved about the system. And the last one was really the usability issues. So the password were constantly seen as too complex to set up, and difficulty completing the form that was already complex in the context of experiencing COVID-19 symptoms, really. And then the rigidity of the system. And this is one that is very interesting. The COVID-19 symptoms list was perceived as non-exhaustive. At the beginning of the pandemic, we weren't really sure what the COVID-19 symptoms were. And I think there's also potential to gather data from participants and then maybe improve the list of the symptoms with time. Inability to put certain information in. For example, my ethnicity was not represented, and this would be shown in the data. So this is some sort of low-hanging fruit. We can improve that very easily, right? Adding some stuff in the survey so it's more representative or represents the reality. So this is sort of just what I wanted to show you. This was really proof of concept. We use one model, and that's open access, and we analyze it using qualitative methods to see whether we could actually find out something about the system on 40,000 data points. So this is, I started thinking about sort of putting together this machine learning method and qualitative analysis, where the speed, accuracy, and cost effectiveness is an attribute of AI. And I call it, as I see myself more as a behavior scientist, the community of words that the machine can put together. But then moving it to human intelligence, which is more about synthesizing, extracting meaning, contextualizing what this all means. And this is all the community of meaning. Now, a little step back, thinking about what happened during the pandemic and my experience. Now, 6.6% of data was analyzed, leaving a wealth of potential insights untapped, really. Too late. So this paper was published more than 2 years after the initial data collection. So this really emphasizing the need for real-time tools, because this mattered in the pandemic. And as I see it, I'm not in public health anymore, so I can criticize as much as I like, but I don't see, I can't see enough lessons learned from the pandemic for the next one or for public health services altogether. So there's still value in that, absolutely. And this is one of the important ones, too general. So as you can see, these are broad findings, obscuring experiences of diverse groups, especially underserved population. And for sometimes I was living and breathing the data because I had to look into it qualitatively. And sometimes I would see a response such as, I'm not going to self-isolate. I'm scared to lose my job. I'm a key worker. I have a son that I need to support now. So what about those financial external reasons. And a lot of the government rhetoric was at the time, people are not motivated. And then coming back to, let's say, behavior insights advisor like myself saying, how do we motivate people who are so lazy and they don't want to self-isolate? Where in fact, it's a lot about the environment and providing facilities enabling people to help them to self-isolate. But if you're worried about your finances, it's another story. And I would argue what we've seen during the pandemic is that people who were from lower socioeconomic status were hit mostly by the pandemic. But those findings are obscured because the model is too general to look into these. So I'll mention that later about when I discuss Humble, but one thing I wanted to mention, since then we validated this analysis where we actually compared human-only analysis with machine-assisted topic analysis. So researchers separately conducted the same analysis, different analysis on the same data. And we did some triangulation exercise, meaning later on we compared what the machine assisted topic analysis does and what human-only analysis does. And we were pleasantly our hypothesis was supported that there was no loss of information. They were slightly complementary, but they were very, very similar. And of course, this is one study, but based on this 1,500 data points, free text responses, we could see that those methods are comparable. However, we also looked at the time efficiency, and with MATA, total person hours is 40 compared to 147 for human-only analysis. And this is not to say that qualitative researchers can now just use AI, absolutely not. But when it matters, I think they can. And this is more those user feedback data that's gathered on a large scale. So now I just wanted to move to a practical application of MATA, machine-assisted topic analysis. This is something that I've been passionate for years and years and years. Some scholars call it scientific regression of the field of digital health, where health apps are downloaded in billions, and most have not been evaluated in rigorous or really any studies. And those apps that have been evaluated in scientific literature, they are not publicly available. Money runs out, grant runs out, there's no sustainability built into the app or the digital health developed. And these are money-making machines as well. So what I wanted to do is use a social listening exercise through social media, in this case, Twitter, to identify whether we could use machine-assisted topic analysis to identify any negative impact of widely used digital health apps, and whether we could do it through Twitter, whether it's unintended consequences or any other issues. And we know about the issues. So, for example, poor diagnostic sensitivity in apps offering screening for skin cancer. That's a classic one, isn't it? But apparently, I spoke to someone, and I think, did I speak to you, Carrie, that those apps for detecting skin cancer still exist, and they are in the app library. They're not supposed to be if they have not been evaluated. I know some colleagues that are working on actually efficacious system like that, but some of them are still in the app library. Some apps that aim to decrease alcohol consumption can actually encourage alcohol intake. And this is a recent one. A major NHS BMI calculator had an error, and it suggested more calorie intake for overweight people than supposed to suggest. So there are errors in the systems. So these are things that we know about. But what about the things that we don't know about? And this is what I wanted to do with MATA. So first of all, I had to find out what are the money-making machines in terms of apps globally. So I found statistics on that, and I was kind of surprised. There were the so-called fitness apps globally, mental well-being apps, so anything to do with meditation, with mindfulness. And the third one is menstrual tracking apps. So those three are the highest grossing apps on the market globally. And then I took the 5 companies that have the 5 highest grossing apps, and I downloaded the tweets that included hashtag or handle of these apps. And then I ran them through negative sentiment because I wanted to identify user issues. Again, this is exploration, whether I could actually find something. And then again, as I showed you before, I used machine-assisted topic analysis. And I'll focus on the menstrual tracking apps. So these are the tweets. So we had 34,000 tweets that met the inclusion criteria. So after filtering through negative sentiment for menstrual tracking apps. So another visualization in the form of a mind map, which I love. But as you can see, so on the right-hand side in blue is those topics created by machine. Again, we described them separately, 2 researchers described them separately and then came together and agree what this topic is about. And then we try to map them onto, we try to do a thematic analysis, whether we can make it a bit more usable for the user. So at this stage in gray is something we put together as a human analysis, mimicking thematic analysis. So the first one, the major theme is human technology dynamics. So this is around psychological and emotional impact of the menstrual tracking app. So first one is the distress expressed by the user because of the pop-ups. Psychological impact. So this is more about how the algorithm that's in there make you feel in terms of monitoring where you are in the cycle and how you should feel. And I'll give you an example of that. An example will be better. And also the challenges with inaccurate prediction. And that's something that's very interesting to me. Cognitive and behavioral dynamics. So using the apps to explain behavior and emotional state that might not necessarily be a negative thing. But maybe not feeling great, and then looking at the apps, okay, I'm about to have my period, for example. And then actually topic 10 was about providing reassurance and justifying behavior. I've done something. There's a good quote where, okay, I had 3 chocolates today, but my app tells me I can indulge today. Whether that's, whether as a public health professional, maybe I leave it, but the app sort of gives you this prescription and say, okay, no, you're fine today. There are issues around user satisfaction. So these are more the usability issues with the app. There's another one, which is sociocultural and privacy concerns. So these are data privacy and security concerns and feminist issues. I appreciate this is not this seems like it's not a coherent one topic. And that's, I think that's an issue with this system as well, as I would mention a limitation of it. This seems like a different buckets, but I'll give you an example of that. And the second really theme was around, well, the role of apps as a platform for discussion and advocacy. So there was a lot of debate around the appropriate content and community management, period taboos, what does it mean to be a woman, everything related to feminist issues, but also gender issues, feminist issues, but also especially recently with the abortion rights in the US, talking about what's going to happen to my data, things like that. But there's a lot of sort of back and forth of discussion around that. And that's quite interesting as well. Let me give you one example of the psychological and emotional impact. So, and I'm sorry about this. Can I swear? I'm sorry about the swear words. It just came that it's not that everyone always swears on Twitter, but so psychological and emotional impact, distress due to pop-ups. So this is one tweet, for example. I'm surprised the app doesn't have restraining orders against them. It's borderline harassment, how they always want you to upgrade to premium. So this is like one of example of what we had in that topic. Topic 7, psychological impact of app monitoring. Me, I'm actually feeling energized and productive. My app, you should be feeling fucking disgusting and half asleep and worthless today. Now, this is quite interesting because the app is telling you something that you should feel, and I'm feeling better. So this dynamics of technology and human and the interaction of it and how you believe the system that is developed by developers, obviously. I swear my period calendar app is like fucking countdown to doomsday. I love that. Countdown to doomsday, that's what your period is. Girls' problems, period props, sorry boys. Again, this is, counting down to something as a doomsday. It's again interesting, but the counting down is provided by what? By the algorithm as well, which is often so inaccurate. And just this is an example of topic 3 challenges with inaccurate predictions. I was late for 20 days in August. I will never forget that month, and I will never forget the app for the stress. And this is just one example. And then last thing I wanted to mention is there's this sociocultural and privacy concern, which it's a bit of a bucket of variety here. I deleted the app, but they still send me emails. I definitely know they have a deal with fertility agency because they literally send me emails about egg freezing, very reckless. The app name, they're protecting users' health information, but it's only protecting it from hacks and data leaks, not from subpoenas and court orders that can be used against individuals who've got an abortion. Not enough, do better. So this is around Roe versus Wade. Is that? Yes, Roe versus Wade in US. These were health tips. They were condescending and unrealistic. Disgust was the only negative emotional experience from reading these parts of the app. Hire writers who have feminist frameworks, as well as knowledge in the areas of medical and mental health. So that's sort of another feedback that I think it's quite interesting. You're actively trying to shut down girls, women who aren't typical feminine girls. You've allowed this nasty group of girls to attack anyone who says they are a tomboy. Instead of stopping the attacks, you're shadow banning and deleting the tomboys' comments. So again, I find it quite interesting, and I'm not quite sure how to present it in the paper and what to do with that. But I think there's a place for that, and yes, other researchers might talk about that, but there's another evidence here from Twitter as a social listening exercise. So I'll finish with. So I'll talk to you about the development and validation of MATA and practical application for Twitter data. And I'll just wanted to finish with talking about the next steps, which is the Humble framework. So here is the focusing on the experience of underserved groups and bias mitigation. So this is Humble, which is a human-centered method for bias reducing algorithms, very long name, with natural language processing or text analytics and qualitative analysis, and this is for improved health outcomes and underserved population. And I named it Humble because I've seen it before in digital health, and I'm sure you've seen it before as well. When there's a certain emphasis, for example, years back when digital health was very much on the agenda, digital health was supposed to change the world and change healthcare, save money, and we will all live happily ever after. Obviously, that wasn't the case. And now it feels the rhetoric has changed to AI will change the world now. And it was in certain environments. And I feel like if we don't have a multidisciplinary working in that space, it can go awfully wrong. And we know that already. So here I'm trying to help to address the larger issue, which is, well, there are large volumes of this free text data that could be analyzed using AI, but those same AI can exhibit biases leading to unfair or discriminatory predictions. And this can amplify the health inequalities affecting underserved communities. So I presented to you before this kind of the thinking that, and I want to show you how it develops. So it's still AI, human intelligence, and creating, in this case, this responsive real-time public health. If we talk about NHS Test and Trace, for example, data, or a next pandemic where we can analyze the actual user data, more granular data, not only the numbers, to improve public health responses. But the overarching theme is bias mitigation, really. So the expected outcomes from Humble work is a Humble roadmap, so the best practices guide for bias mitigation, and this analysis framework that combines NLP, qualitative analysis, and behavior science. And insights, intervention recommendations, so user experience. So I'm planning to analyze this 500,000 responses and use other free text data sets that include free text and socio-demographics. If you can think of any, let me know. There's a potential for collaboration here if you're interested. Also a systematic way to enhance engagement with underserved population. And also in the last work stream, I want to implement Humble for routine use in UK Health Security Agency. So this is the organization now responsible for managing pandemic, and they own the data for NHS Test and Trace. So first I'm doing a multidisciplinary review, and this is how I think about it. If I think about where bias can creep in, this is a simplification from data being collected is not representative through to algorithmic architecture issue if the data is trained on non-representative sample, and then also interpretation issue when humans take it and they introduce bias themselves, not knowing, not being expert in that field, or not including patient and public representatives or consumers, as it's called here more likely. And here I've seen before when we talk about, let's say, data scientists, they might call bias as an algorithmic error that stems from skewed data. Yet a critical approach here would be bias reflects societal structure influenced by cultural and political context. So this is the review I'm doing at the moment. I'm trying to gather some studies about how to mitigate bias, but not only in data science. I found out very quickly that mitigating bias in natural language is a wicked problem, and there's no good way of doing that. And I was really hoping that data science has all the responses I need. I was very naive, so I can just implement that and it's going to be great. I think it's a bigger issue than that. Still, I'm persevering, so I'm doing this multidisciplinary review to map bias a little bit. And then work stream 2 is really extracting and stratifying the NHS Test and Trace insights and doing the analysis by socio-demographics. And the socio-demographics I have access to is region of England, age, gender, and also some information about digital health literacy. It's not perfect, but that's something I also need to do is advise, recommend heavily how this data is collected in the future. So we have a little bit more understanding of social inequalities beyond those more traditional, such as age and gender. So in workstream 3, I aim to use, again, qualitative analysis to analyze the data. And also I want to include behavior science models to hopefully automatically classify some of the barriers experienced, and I'll mention that in a second. And workstream 4 is really repeating the same process on different data sets. So kind of generalizing Humble for other use. So on the left-hand side, you can see this is a COM-B model. So this is a model of behavior or behavior change. For any behavior to occur, a person needs to have capability, so the skills and knowledge to enact the behavior. They have to have motivation, and it's automatic motivation, impulses, emotions, cues, but also the more the motivation about deliberate decision making, so goal setting, action planning, and then the opportunity. And opportunity, social opportunities such as norms in the society, but also physical opportunity, whether they have things in the environment to help enact behavior. And based on that, this is based on 33 psychological theories. This is a behavior change intervention ontology, which has different construct in it. So for example, let me give you an example. This is self-efficacy, belief of behavior. Now, I don't know what to do with that, but I want to use that at some stage to try to classify the user feedback. So this is a testable hypothesis whether I can do it or not, but use this kind of system to automatically classify. So I'll leave you with that because I have no idea how I'm going to do it, but I heard it is possible. It is possible, but that's where my knowledge ends at this stage. And then bias detection and mitigation. I'm hoping to get well, a lot of knowledge through my interdisciplinary review, but there will be sort of two stages I can see it with data detection and mitigation. I know at the data assessment stage, I could use some quantitative metrics to see, to assess whether there is bias, but also qualitative audits. So things around explainable AI, showing the data to people and working with them to interrogate the algorithms, how they are developed, and also at the output assessment. So this dual qualitative analysis approach where at least two people analyze the whole data sets separately and they come together, but also an extremely important evaluation and improvement loop with patient and public representatives, with experts and stakeholders. And the last thing is implementation. So once this framework is developed, I would love to implement that. Well, there's a plan to implement that as UK Health Security Agency being my collaborator, test and refine the Humble for routine use. Can we actually implement it? And now I was thinking today when Kit was talking about the simulation lab, whether we could do some user testing. I must talk to him maybe. And this is really my last slide. So at this stage, I'm also developing community. I'm not so great at speaking to people and ask for advice. But you know, this is what I need to do as a researcher. You need to do that. So this is some areas. If you are interested in health inequality, ethics and bias mitigation or critical approaches will be great. Or just interested in making healthcare or public health data more efficient and actionable. Social sciences related to health, and data science and technology, because this is where what my steep learning curve is, really machine learning and natural language processing. And any free text data that you might think of. As I said, I'm looking for different data sets that can be shareable and actually to analyze it and analyze it together. And just some acknowledgement. Thank you.
That was a wonderful, rapid tour of a really interesting research topic. It's a really innovative research design and indeed an invitation to collaborate in research for anyone who's been part of tonight's seminar. And I'm sure there must be questions and comments online. Shaz, would you like to help us with those?
Yeah, absolutely.
Thank
Paulina, we've got this presentation is fantastic. So echoing what Pauline says, we've got a question from Liz online. One of her mentors in Austin Health is going to be tackling a 45,000 patient feedback response. So would be grateful to benefit from you, like connecting, and would also love to hear more about Humble. But one of the key challenges in public health is that she doesn't always get responses from minority populations. So any suggestions on how they can improve that? So
Absolutely.
any advice?
Actually, I was yes, absolutely. I was in Digital Health Festival last weekend. I was an equity partner, and that was exactly the question. I remember my first job as a research assistant was recruiting people with HIV to a trial to help adherence to medication. People who normally would actually not want to take medication for HIV for reasons of stigmatization. And I was planning to write a paper on how to recruit the unrecruitable. And now looking back, the language just sounds wrong, doesn't it? Recruiting the unrecruitable. So my thinking have changed a lot. And what I can answer is that I think all of us in the room would have different ideas of how to engage with those communities. I think one of them is starting with, if you develop an intervention, you need to co-design it with them. So reciprocity, and if you design something, you're not getting data out of them and nothing for them. So it's a process of co-production, co-development to get versatile people involved. Other than that, maybe anyone else who would like to who have some ideas. One good thing is that I'm thinking about free text response specifically. It does require a smartphone, I must say, but it doesn't require too much digital health literacy. I'm thinking, because you can just dictate nowadays. It's better than before. You can just dictate something on your phone and send it off. So we can have a system to gather that feedback very quickly. So I worked with a little startup that aimed to create a digital intervention for kids and their families who were Ukrainian refugees. And this is something that we gather the feedback from, asking them to just record themselves and see how they are using the digital health tool.
Thank you. Anything else online, Shaz?
I have asked them to type it in
Mhm.
or go off mute.
All right, so if you're online, this is your chance to comment or ask Paulina for her insights around the table. Do we have any comments or questions? If not, I have one, at least one. And that's around, I guess, workforce, making data more efficient and actionable somehow requires a public health workforce that is able to deal with the interpretation, is able to work with a system of information to action. As a public health worker yourself, what are your thoughts on translating the ability to act in an informed way with the actual capacity of the health system workforce to do anything about it?
Absolutely. And I think, I've seen this before because I spent 3.5 years in public health organization. I feel like I have a little bit of confidence that I have a sense how it may work in terms of, a pipeline of how, let's say, Humble could be implemented. So before, let's say, program board during the pandemic would meet every 2 weeks. And then they would make decision based on numbers and some feedback that may have been anecdotal. So let's say every second week, the numbers of contacts and cases were reviewed, feedback was gathered, and not systematically, of course, but from different centers, and then decisions were made of how to improve certain things. Now, I can see it in 2 ways. So there's a data science group, and then, for example, there's us, behavioral insights. There was a beautiful pipeline developed in data science where one scientist would focus on analyzing one part of the system, hand it over to another one, and hand it over to another one. That was a great pipeline to do in the pandemic because one person would focus on one task. Now I can see Humble being like that. So let's say you have structural topic modeling or another model that could be implemented by data scientists. Then they create the output, move it to qualitative researchers, for example, in behavioral insights, and we pass it on to program board. It's very much implementable, and this is something I'm working on and trying to test later on once I develop the system. It needs to be very usable and it needs to be fast, especially in the context of pandemic. As long as it's systematic, I feel like it's more possible the public health professionals will engage with that. And also I will develop it with them. So I put together in my grant about 6 or 7 workshops with the users to say, okay, let's develop it together. Do you find it useful?
I have another question, but I want to pause to see if anyone else is in the loop. Okay, so I mean, your data has come from online feedback and from social media platforms like Twitter and so on. So presumably one way that the public health workers could respond to the information they receive about feedback and its sentiment and so on is through social media platforms. Is there, I mean, do you see Humble being able to guide the public health profession in how to actually counter negative sentiment online or engineer public sentiment in online forums?
It's an interesting question. I think, so when I'm looking at intervention development, so there's humble, there's actionable insights, which means really, what are the barriers? What are people saying about the service? Is it environmental? Is it knowledge base? Is it motivational? And a lot of it will be environmental, such as worries about financial costs to isolating. So what I'm trying to do, and hopefully with the COMB model, try to classify those, and then based on whether this is an environmental issue, whether this is a motivational issue or knowledge issue, try to create intervention that would most likely target this behavior. Because COMB is part of a behavior change wheel, which suggests after you've identified your barriers, how to intervene. So you don't intervene on an environmental level with trying to increase someone's knowledge, because it's not going to work, because the knowledge is not the issue. So in that terms, what I wanted to do within Humble is create those interventions that are more tailored to the barriers people experience.
Mhm.
But I mean, I know that there's some studies done with analyzing social media and to target messaging, to create target messages in the pandemic to sort of counteract that, but I don't know how effective they are. Does anyone else know about?
Lots of potential for more research there. All right.
We do have another question online if
Please.
we've got some time. Again, great presentation, amazing project. This person would like to draw a parallel between the health data and education data and predictive analytics, and really around that mitigation of bias in linked data. So they give an example about in the UK, where there's a potential to link education data with health data, with education data to identify a causal relationship between health issues or special learning needs or student progression. And however, in that case, decision or predictive analysis of student performance in relation to their special needs or other attributes, including ethnicities, it's not always clear how they're reached. So do you have any comments on that mitigation of bias when it comes to linked data? I know it's a bit of a big question.
This is very complex. No, actually, I don't know how to answer that question. I think that's important. So the linking the education with the health data, is that?
That's what it sounds like, yeah.
Anyone has any comments or ideas? Let me see. Oh no, I'm not logged in. I think at
But
this.
their overall question is just, how do you handle bias with linked data in general?
Wow. It's at this stage, we don't even know how to handle bias in natural language very well. So I think that that's my understanding. So in terms of the linked data, I would not. This is an interesting question, actually. So we might want to link up to think about this in the future of Humble.
All right, well, there's an invitation to whoever posed the question. Follow up with Paulina, please. Yeah, it seems to me that, I mean, we know so much ongoing about social determinants of health.
Yes.
We also know that a lot of the structured health data that we collect doesn't go near the data about many social determinants, including, you know, your geographic area, your walkability of your suburb, education level, many, you know, your digital access and literacy in general. So there are so many possibilities for missing important factors when we look at a single data set or we start to link data sets. It seems to me that one of the checks that you put in, which is lots of consultation with representative groups in the population, is at least one way to foreshadow when there might be real problems with your analysis. If your analysis does not resonate with very many of the people for whom you're doing work.
Absolutely. I think when I was learning about this, the social determinants of health nowadays, because it's such a hot topic, some companies start to not gather this kind of data, because if you don't gather this kind of data, you don't have to do anything about it.
Yeah.
Because it's difficult and it's sensitive. And yes, if you don't have skills to do anything about it, then you might want to, in a context of a company, let's say, not gather this kind of data. So I think gathering of this kind of data, even in NHS Test and Trace, I mean, we've got gender, age, and region of England. So we've got really, it's better than nothing. But I think part of my work stream is also to make sure that we gather a bit more than that. There are at least how many? 9? Is it that 9 protected characteristics? And so we can gather much more data.
All right, anything else on lunches? Anything else around the room? All right, could we please say thank you again to Paulina for really excellent insights into her work? And please do follow up with her at her invitation if you're interested to know more. Thanks very much, everyone.
Thank you for your time.